Dr. Purendra to take his talk on Phakic IOL. After that, we'll be left with intracorneal rings and keratoplasty for the treatment of keratoconus.
And the use of phakic lenses in keratoconus is really gives an amazing results. And I am Dr. Purendra Bhasin. I don't have any financial disclosure. So, phakic IOL are the ICLs are a special kind of intraocular lenses which are placed in front of the natural lens of the patient to treat myopic, hyperopic, or astigmatic refractive errors. The Vision ICL, which comes from the Star Surgical, received its FDA approval in the year 2005, and for correcting the nearsightedness between -3 to -20 diopters of refractive error. And use of ICLs in keratoconus started in the year 2008. Keratoconus per se presents with a various complicated clinical environment for the refractive correction, as there is a abnormality in the cornea, and which has the potential for the progressive deterioration if it is not cross-linked. Higher order abrasions due to corneal irregularity limits the eye potential for the best spherical corrected visual acuity. Especially important abrasions are very negative spherical abrasions, ranging from -0.35 to -1.50, and a high comma. Special optical considerations are there is a disparity between the corneal vortex, visual axis, pupillary axis, as there is no coincidence in between the two. That's why the quality of vision is deteriorated. Various combined treatment options are proposed. We can suggest a contact lens, which could be RGP, Rose K, or scleral contact lens, plus or minus cross-linking, if it all depends on the age and the progression of the keratoconus. Intracorneal ring segment plus cross-linked cornea, this can be done. And then the transepithelial, the LASIK treatment, and topo-guided LASIK treatment with cross-linking. We may combine ICRS with cross-linking with topo-guided laser treatment altogether for the better quality. And mind it, the topo-guided laser and cross-link can be done in one sitting, and or maybe we can do ICRS first and cross-link it. So, then we can correct the refractive error at a later stage, or we can go for straight away for the cross-linking, cross-link cornea, and then do ICL. And in between these two procedures, there should be a minimum gap of 6 months, or ICRS, CXL with ICL. That also is suggested when there is a large eccentric cone. Various studies have been published for the safety of the ICL in the keratoconus. As you can see, there is a literature review. And we will be discussing on the toric posterior chamber phakic lens with or without corneal cross-linking in keratoconus. ICL, it comes from the Star Company, is a monoblock single-piece plate haptic foldable lens made up of a polymer material which is extremely hydrophilic and with a highly biocompatible flexible collagen polymer with a refractive index of 1.452 and is permeable to oxygen and the nutrients. Can you please be silent? It is designed with the central wall to be implanted in the posterior chamber behind the iris with an aqueous humor layer separating it. And this is responsible for the avoidance of the development of cataract and the proper nutrition of the crystalline lens. And the lenses haptics are resting on the ciliary sulcus, but definitely there is a sizing issue if it is not of a proper size, appropriate size. It lies behind the iris and it is far from the endothelium, excellent cosmesis, and invisible to the eye, close to the nodal point. That's why it gives better quality of vision, and gain in the retinal size image is there, and greater effective optical zone at the corneal plane, and that's why there is a less chance of glare and halo. Located in the sulcus, stable location, good for toric design, and easily removable, exchangeable. So that is why it is called as a reversible procedure, and no fixation into the iris tissue, and does not alter the shape or remove the corneal as we do it in the corneal based procedures. The advantages of ICL is it that it is able to correct high degrees of myopia plus astigmatism, which could not be corrected with other surgical procedures. Patients are not a suitable candidate for LASIK in most of the cases, and there is less likely to cause an or contribute to the dry eye. It is available in the power of zero point 0.5 to minus 18 diopters, and up to 6 diopters for hyperopes, and it corrects up to 6 diopters of astigmatism, and it has got a central 320 microns 360 microns opening, which manages the aqueous in front and behind the lens, and it maintains the nutrition of the crystalline lens. And for the redundancy, there are two extra ports on the either side of the optic of the ICL. Then comes the Indian counterpart, that is IPCL, and as all these cases, the astigmatism is very high and the refractive error is also very high. So this lens is having a similar design with the vault, but the material is different. It is a hydrophilic acrylic material, but it can correct up to minus 30 diopters, and with the correction of plus 10 diopters of astigmatism, and we can change the customize the overall length of the lens also from 11 millimeter to 14 millimeter with a 0.25 millimeter steps, which is not possible with the ICL. So customization is possible with our Indian lenses. So coming to the workup, we have to select a patient of 21 to 40 years of age group with a myopia ranging from minus 3 to minus 23 or 25 diopters, or up to 30 diopters also, with the astigmatism up to 6 diopters. The important thing is that refraction should be stable for with the less than 0.5 diopters of change in last 1 year. Anterior chamber depth should be more than or equal to 2.8 millimeter. In keratoconus cases, there is unusual high anterior chamber depth from the corneal endothelium, which is moreover falsely recorded. So I usually go for a 3 millimeter minimum anterior chamber depth in such cases. Stable refraction. The patient should have a best corrected visual acuity of at least 20 by 50 with no previous ocular surgery, normal intraocular pressure, and open anterior chamber angles. The peripheral retina should be normal, or it should be treated with by laser photocoagulation when it is necessary, and the patient should not have diabetes or other systemic illnesses. It is indicated in cases of keratoconus or form of rusty keratoconus when we avoid doing laser cornea-based procedures with a good spectacle corrected vision, and in the absence of clinically significant irregular astigmatism. And clinically significant irregular astigmatism means when there is a difference greater than one line of corrected vision between the glasses and the RGB contact lenses. So if there is a difference, the improvement is more with RGB contact lens by one line, then it is a clinically significant irregular astigmatism. Relative indications are in keratoconus with by after we have stabilized the keratoconus by CXL, and or in cases where we have done DIALC or PKP. In such cases also we can rehabilitate the residual refractive error by using the ICL. Moderately good vision, but with poor tolerance to glasses or contact lenses, because these patients, they are very often they are intolerant to contact lenses. And anisometropia with adequate refractive anatomy and stable refraction. The contraindications are progressive keratoconus with unstable corneas, young patients less than 20 years of age, because these are very unstable patients, and highly aberrated eyes, total higher order aberrations of more than 3 microns with poor best spectacle corrected visual acuity less than 0.5. Complete preoperative assessment is done, best corrected, uncorrected visual acuity, cycloplegic and manifest refraction, slit lamp examination thoroughly, IOP should be within normal limits, angles should remain open, topography, tomography and keratometry done as has been elicited by Dr. Bharti, and endothelial cell count should be more than or equal to 2000. This is very important. Fundus examination important to be given to the retinal periphery. Anterior chamber depth should be more than or equal to 2.80, and this should be excluding the corneal thickness. And another important thing is the wide to wide measurement. Anterior chamber depth already have said, and wide to wide measurement is done with the help of calipers, as you can see here, and we can check it with pentacam or IOL master, which I am doing regularly in all our cases. And then coming to the ICL sizing, the accurate preoperative wide to wide and anterior chamber depth measurement is very important, and which I want to emphasize here, and because it provides a vault, and the vault is the distance between the posterior surface of the ICL and the anterior surface of the crystalline lens. So this distance should be compared with the cornea. As you can see here, there it is marked with the red arrows between the distance, and in this particular case, the corneal thickness is similar to the vault, and vault is around 500 microns, because we assume that the corneal thickness is around 500 microns. The ideal sized ICL will give a vault of 0.25 to 0.75 millimeter, or half the corneal thickness, and up to 1.5 times of the corneal thickness. Undersized ICL is 1, which gives a less than 0.125 millimeter vault, like it is almost touching the surface of cornea, and there is an increased risk of anterior subcapsular cataract development. An oversized ICL is when the vault is more than 950 or more than 1 millimeter or 1000 micron, which can be checked with the help of pentacam, and which will push the iris from the periphery and angle the close the angles, and will lead to the development of glaucoma. And this is the ICL vault. As you can see, the ICL in front with the yellow and green arrow, there is clear space in between, which is vault, and this is the anterior red arrow is the anterior surface of the lens, and this is the low vault, as you can see. Coming to the cases, clinical cases, this 28 years old female had keratoconus with post C3R 14 months back. The unaided vision was 3 by 60, and refractive error was minus 8.25 to with 3.5 diopters of cylinder, and best corrected vision in both eyes was 6 by 9. So this is the pentacam, and you can see the pachymetry in the right eye is 437. Minimum pachymetry is 437. This is the anterior surface, this is the posterior surface, and this is the pachymetry here on the bottom left side. And this is the Bellin-Ambrosio enhanced ectasia index. Here again, it is all the indices are red. The cornea is very steep, and it's a case of post C3 CXL keratoconus. More in the right eye, and the left eye keratoconus is also there in this particular pentacam. And this is the surgery which we did, and the surgery part is very easy. I think the preoperative assessment is very important, and you make an incision of 3.2 millimeter, or maybe some of us are using 3 millimeter incision for the ICL. This is the ICL, and this is loaded in the cartridge and injected in the eye in the presence of viscoelastic methyl cellulose or sodium hyaluronate, and with the help of the spatula we push the haptics and behind the iris in the ciliary sulcus region. This is being a toric lens, so we align the lens in the axis which intended to be implanted, and this is very simple. It hardly takes 2 to 5 minutes for completing the surgery. And the post ICL, toric ICL, the vision which patient received unaided was 6/9 part at 25 days, and at 2 months both the eyes the vision was 6/9 and 6/9. So this is the excellent result which we get, and the results are predictable in majority of the cases. Another case, 35 years old female, right eye keratoconus exotropia and post squint correction post C3R, and patient had amblyopia, which was squint correction was done and C3R was done in 2030. Pre C3R, this is the condition of the right eye and left eye in the table, and C3R right was done in 2013. After the C3R, the vision remained same, and the patient maintained the vision. And then in the year 2022, the patient came for the refractive correction. The pachymetry in the right eye, as you can see, the pachy in the left bottom graph, axial graph, is that it is back surface is very steep, and the thinnest location, thinnest corneal pachymetry is 433, and the 55.8 is the corneal maximum K reading. And this is the left eye. Pachy in this eye is 518. So we could maintain and save the vision of the left eye to 6/9. And this is after the squint surgery, which was done in the month of June 2022, and refractive surgery was done later, toric ICL in both eyes, and the vision improved to 6/18 and 6/9 with the use of -8 diopters with 6 diopters correcting ICL, and in the left eye -6 diopters with 2.5 diopter correcting ICL. Another case with post C3R, vision improving to 6/6 part and 6/9 part, young patient, low myopia and low to moderate myopia. Similar picture, we could give a good quality of vision, and the vision improved in this particular case to 6/6 in both eyes, 6/9 in both the eyes. Last case, because we have to add some cases where the keratoconus suspect is there, and young patient, there was a high myopia, 11.5 diopters with half diopter cylinder, and 8.5 diopters with 2 diopter cylinder. Such cases, laser-based procedures are avoided better, although the pachymetry was 551. Cornea was not very steep, but in the left eye you can see the back curvature. There is a sign of the suspicion in the posterior surface, and the D value was on a higher side. Similarly, on the left side, looking to the high myopia, there was a keratoconus suspect. So after checking for observing for 1 year that there is no progression in the refractive error, we performed ICL and toric ICL in both eyes, and vision improved to 6/9 and 6/6. So friends, to conclude, first we should stabilize the cornea in cases of progressive keratoconus by cross-linking. One may use ICRS or intracorneal ring segment in cases of decentered cone and to decrease the irregularity and make the cone central, and wait for at least 6 months or more for the stability to plan phakic lens. Phakic intraocular lenses are very effective and safe for the correction of moderate to high refractive errors in both keratoconic and non-keratoconic cases, and there should not be any corneal opacity, and stability of the disease should be confirmed before considering any refractive procedure. I thank you for your patient hearing. Any questions?
Any questions for Dr. Purendra?
So, Dr. Purendra, what is your cutoff time when you take up the patient for toric ICL after cross-linking?
For 6 months, minimum 6 months or more. I will prefer, because I have seen that even after 6 months, there is a process of healing occurs and the remodulation of the cornea occurs, and we should observe that there is no change in the refractive error.
So have you encountered any case in which the refraction changes after ICL?
Pardon?
Have you encountered any case
Because all my cases are not done early; they are done after 1 year, minimum 1 year, and after ensuring that the stability of the refraction is there post CXL. We I have not come across with any major changes,
And
and
if it changes, then what options we have?
we have other options. If the refraction changes, we can do topo-guided lasing or surface procedure. We can do in such cases if the change is more and the patient is willing.
Thank you.
That is more important. Yes.
Is there any difference that you noted in the outcomes between glamour ICLs and IPCL?
Truly not much. Not much.
IPCL or glamour ICL?
But look, it all depends. I will prefer ICL because polymer is the material of choice for me. But in cases where the astigmatism is more or the refractive error is high, where we are unable to correct fully, because we see that one case is 19.5 diopters, which we cannot correct by the Collamer lenses ICL. So because to give full correction is the aim what I do, and in such cases I prefer IPCL. And otherwise, if the patient wants is not affordable, then I go for IPCL. Otherwise, my first choice is ICL only, Star Company. Yeah. No. Surgically it is same. Yes. After intact. Yes. After stabilizing the cornea, we can do.
Excuse me, sir. What is the reason for the preference of ICL over implants?
Material. And that is long term.
Have you found significant problems?
No.
So, for the
transparency
IPCL
is
or
better.
any material which is used after the extraction of the lens, crystalline lens, there is no study of more than 5 years, whereas the Collamer is there for last 23 years. So there are long-term studies available with the material for the ICL, but there is no.
I'm just asking in your personal experience.
So we have not. I have not.
Have you found any complications with IPCL material?
So I have not put it personally. If you ask me, I have not put IPCL because I am very conservative, and I have to be very sure that whatever I am putting in some patient's eye is the one which I want to put in my eye as well.
So I fully agree with your emotion, but a lot of us have been using
It is not emotion. It is science. It is not emotion. No emotional thing. If the material is not approved for putting over a normal crystalline lens, and there has been no studies except for the fact that you can make the manufacture without any approvals in our country. There is no other thing. There is no scientific basis of manufacturing those lenses with the crystalline lenses. There is no study.
So are you telling me that IPCL is not an approved lens?
I am sure it is not. Have you seen
Not
any
FDA
approval?
approved.
Not have the
Not FDA approved.
No.
But DGCA.
By the Indian
No.
DGCA has approved.
Huh?
Then only we can market it. But the thing is, what I have seen is that some extra reaction is seen in few cases when we use IPCL, but otherwise it is, and I use both.
So I've been using ICL from 2008, and last 5-6 years I'm using IPCL. I don't find any difference in my patients.
Many patients are there, and it's a personal experience.
Yes, I think
I should go for that.
there is nothing emotional in these scientific sessions. First thing you must understand that there is nothing emotional on that. They only when I said it that I'll not put it in my eye, that was not emotional. It is because of the science that I'll not put it. Like I have burnt my fingers with the hydrophilic lenses implanted 20 years ago, and each one of them going opaque over a period of 5 to 6 years. And I have explanted many such lenses, not less than 50 or 100, I am telling you. So hydrophilic material, over a period of time, I don't know what is going to happen. and you're putting it in a eye which is young, in the age group of 20 to 30. So that you have to be very, very, cautious and careful, and you have to be giving that kind of care to the young patients